Hello everyone and welcome to Edusurg Clinics. I am Dr. Gunjan Desai and today we are going to have a very important discussion on pancreatic cancer management. And the first part of this series is going to discuss on resectability and operability. So there is a lot of discussion on when to operate a pancreatic cancer patient. And what we are going to do is we are going to simplify these concepts for you so that when you are studying pancreatic cancer or when you are seeing these patients, it becomes very easy to plan their management. So the first thing that we need to understand is whenever it comes to cancer, resectability is different from operability. Okay, resectability is more about the tumor whether it can be surgically removed or not. Is it resectable? So the patient is not resectable, the tumor is resectable. The factors that will determine resectability, as we will see in pancreatic cancer, but in general, it can be the size of the tumor, it can be the location of the tumor, the local spread, say the lymph node extent of the disease and metastasis. On the other hand, when it comes to operability, which is more important, we are discussing the patient's ability to tolerate surgery, right? So a tumor may be resectable, but a patient may not be operable. And that is the importance of this presentation, that you understand resectability as well as operability in pancreatic cancer. So when we talk of operability, and we have already discussed in our videos on liver cancer, how operability is different from resectability, you are looking at overall health, the cardiopulmonary reserve, the frailty of the patient, and many other factors that we will see in this presentation, particularly for pancreatic cancer. So, as I always say for cancer management, as we have seen in the liver cancer videos as well, first assess the patient. Don't see the report and don't reply on WhatsApp that the patient is operable, right? You need to see the patient, understand the patient's fitness. That will see if the patient is operable. If yes, then you look at the organ fitness. For liver, this is very important step. A liver may be cirrhotic child C, then no matter the lesion size, you can't operate the patient unless the patient is going to have a very minor resection or patient going for a transplant. Same thing applies in pancreatic cancer. And then you look at disease and its resectability. So operability for the patient, fitness of the organs in the body, and then disease resectability. So now coming to resectability, there it is a very simple concept to understand. There should not be any evidence of widespread dissemination of disease, or in simple terms, there should not be metastatic disease. For pancreatic cancer, how we can say CA 19-9 more than 500 usually indicates vascular involvement or metastatic disease. Very high CEA, usually more than 100. Ultrasound can show liver lesions or peritoneal disease. PET-CT is probably the gold standard when it comes to assessing metastatic disease. If all these tests are borderline, we do staging laparoscopy before proceeding to surgery. And staging laparoscopy can also suggest widespread dissemination of disease. Once you have ruled out widespread dissemination or metastasis, then we look at TNM. So this is very easy to understand and remember. If you understand the staging of pancreatic cancer or the resectability criteria, we know it is TNM, right? Tumor node metastasis. So once you have ruled out metastasis, then you look at tumor and nodal status. Most commonly, this is done on a triphasic pancreatic protocol, CT or MRI. Other option for local spread is endoscopic ultrasound. So we can have endoscopic ultrasound for assessment of local spread if it's available and if it's required, right? Resectably reads if the patients come to OPD directly, say you say 100 patients of pancreatic cancer, data says that only 25 of them are resectable at presentation. Of course, the neoadjuvant therapies, radiation, everything is trying to increase this pool, but currently the number is 25%. It's even more dismal in pancreatic head cancer. It's only 10% of them which are resectable, vis-a-vis 75% of ampullary tumors which are resectable. I'm sure you would have heard terms like resectable, borderline resectable, locally unresectable cases of pancreatic cancer. If you have not, don't worry. If you feel this chart is very complicated, don't worry. We are going to simplify it for you. In essence, understand the anatomy. If not, we will be putting up videos on pancreatic anatomy as well. We know that superior mesenteric vein, superior mesenteric artery are in very close relation with the pancreatic head, neck, and the uncinate process. Celiac axis, common hepatic artery, is in very close contact with pancreatic neck as well as pancreatic head and some part of pancreatic body. Inferior vena cava is posterior to the uncinate process, right? So if you know this anatomy, we have to understand that if any of these vascular structures are involved, resectability becomes difficult. And that is where we have terms like upfront resectable, that is a clear-cut resectable case. Then you have borderline resectable, that is the case is resectable, but there can be vascular involvement which will need reconstruction. And then you have locally unresectable, basically cases which are unreconstructible or cases where you may reconstruct with grafts, but the survivals are very poor, right? So MD Anderson, NCCN, AHPBA, SSAT, there are a lot of groups that have given these criteria. But simply what we usually follow is the NCCN criteria. In resectable cases, the superior mesenteric vein, portal vein junction is not involved by the tumor, or there is less than 180-degree contact without change in the shape of the tumor. Okay. So locally unresectable is where the involvement is unreconstructible, and all cases in between, whether it's abutment, more than 180-degree involvement, tumor thrombus, or a reconstructible occlusion is borderline resectable. Now coming to superior mesenteric artery, no involvement is resectable. Encasement more than 180-degree is unresectable, and less than 180-degree tumor contact is borderline resectable. Now the other two structures, celiac trunk, more commonly involved in neck body tumors, no involvement. Remember that for artery, 180 degree is borderline resectable, and for vein, 180 degree is resectable, right? That is how you can remember. For all cases, unreconstructible involvement is locally unresectable. For arteries, more than 180-degree involvement is locally unresectable. And for borderline resectable, in case of arteries, the interface should be less than 180, right? So this is something that you have to understand. For common hepatic artery, it's important that you understand that Appleby has given a very different concept based on the involvement of gastroduodenal artery, but that is beyond the scope of this definition. So we will not confuse you. So let us see some of the cases that we have managed. In this video, you can see that the superior mesenteric vein is free, superior mesenteric artery is free. This is the tumor. If you have not identified it by now, tumor is usually hypodense when it's adenocarcinoma. You can see intrahepatic biliary radical dilatation, gallbladder that's dilated, and this is the tumor. So this is clearly resectable adenocarcinoma. Another case, there is a stent in the bile duct. You can see the tumor. You can very well see the tumor here. The vein is closed, less than 180-degree, but there is no contour irregularity, right? You can see that the shape is maintained. So this is again resectable. On the other end, here you can see this is the portal vein. SMV should be in this area, but it's completely occluded. The tumor has completely compressed the SMV. You can see gallstones in this area. And this is a case of borderline resectable pancreatic adenocarcinoma. Another case of pancreatic body tumor, but you can see the tumor around the celiac axis. This is the celiac axis, the splenic origin as well. You can see that the tumor is extending in this area. This is a locally advanced and unresectable pancreatic adenocarcinoma, right? So that is resectability, and some of the cases we also have a separate radiology playlist where we have discussed a lot of cases on pancreas, so you can have a look at that. Now coming to the second part, and this is actually a very important part, that is operability. So for pancreatic cancer of the head, the surgery is a Whipple procedure, which is a very morbid procedure, and that is why assessing patient's fitness is very important when it comes to these surgeries, right? So that is why this ABC classification has been proposed, and it's a very good classification because it also assesses operability and not only resectability, right? So the resectability that we discussed so far is A, that is anatomical. So A is anatomy, B is biology, C is conditional. Basically, C assesses the patient fitness, B assesses the tumor biology, and A assesses the anatomy. So resectable, borderline resectable, locally advanced or locally unresectable is A, right? Then we have biology. What defines biology? CA 19-9 more than 500, regional lymph node metastasis can be seen on PET biopsy if it's done. So that determines the biology. If biology is bad, it is type B or AB in borderline resectable, or LA type AB if the biology is bad. Coming to conditional, type C is where the performance status is poor, and these patients usually cannot undergo surgery. If the patient has type B and C features as well as some features of type A, that patient will be type ABC, right? So that is how you can classify the tumor based on this classification. Okay. Understand that there are criteria which also discuss involvement of inferior vena cava and many other structures in resectability. For a basic understanding, you have to remember these four structures and the ABC classification for pancreatic adenocarcinoma. Thank you.